request the Sunil Apsingi to talk on management of implant failure and non-union in the intertrochanter fracture.
A wonderful program. So I'll talk about management of implant failure and non-union in treatment of intertrochanteric fractures. Fixation of intertrochanteric fractures is highly successful, as we all know. All of us have very good exposure to this fracture, and all of us have very good ability to fix these fractures. We have our own preferences, and like what Srikanth said just now, I myself am a young person and I prefer nails, contrary to what Srikanth just said. Yeah? And there is a very low failure rate. There is some failure rate, but the failure rate is pretty low. The causes of failure of fixation are, number one is inadequate bone. Inadequate bone, is there something we can do about it? We have to think about it, ways to devise, ways to find out if the bone is adequate or not to hold a fixation. Second is improper implant, that is in our hands. Third one is inadequate fixation. Inadequate fixation in our circumstances is sometimes not completely in our hands, because the kind of instrumentations that we have with the constraints that we need to work in doing our jobs, sometimes you find that the instrumentation is inadequate, which causes problems. And implant failures, even the best of the best, the Synthes and all the imported implants, they also fail. They also break. And infection is the other one. If we see the quality of the bone, there are a couple of studies. What they've tried to do is they've tried to do the BMD of the bone on the opposite side. When you have a fracture on one side, they try to measure the BMD on the opposite side and see when do these implants fail. And they found that when the BMD is less than 250 milligrams per centimeter, there is a high risk of fixation failure of surgically fixed pertrochanteric fractures. Now, tip apex distance, which we all know is so popular in DHS, but what they have found is even in PFNs, the tip apex distance holds good, and you need to make sure that you maintain that tip apex distance even for the PFNs. It's a bit difficult to find out what to do when you're using two screws, but when you're using one screw, definitely this thing as DHS holds good. Now, whatever Srikanth says, I'm pretty sure most of the people over here are young and they want to do nailing rather than a DHS. And what we can say is, what I've seen myself is, if you look at the literature, the older literature where they had older nails, they had more problems. As we have progressed, as the new nails have come into the market, we're finding that they are far superior to the older nails, number one. But one of the most important problems for us lies in the locally acquired implants. They are not always up to the mark. Inadequate fixation, as we can see here, sometimes inadequate fixation happens inadvertently because of so many reasons that can go wrong in an operating theater. But when you have an inadequate fixation like this, when you have just one screw holding the fracture, this is definitely going to fail, and once that fails, you need to make sure you have a plan B to make this patient walk immediately. Implant breakage, the incidence of implant breakage is around 2 to 6%, and it happens not only in our locally made Indian implants, but also in the so-called good quality imported foreign implants. Any implant can break, and you need to be ready for that. And most commonly the implant breaks because the fracture has not healed. So you need to find out what are the reasons why the fracture is not healing and the implant's under stress and it's breaking. So that is what is required. Next is the choice of salvage methods in failed fractures depends on the physiological age of the patient, the activity levels of the patient. You might have a very old person who is very active, and then he needs some good fixation method so that he can walk immediately. The remaining bone quality, which is very essential in deciding what to do, viability of the femoral head, and the status of the articular cartilage in the hip joint, the articular cartilage on the femoral head as well as on the acetabular side. So you can see here in this X-ray, you can see on the left side, on the DHS side, you've got the head is destroyed and it's going and eating into the articular cartilage, the screw, and at the same time you've got bone loss on the femoral side where you've got lots of screws which are stress raisers, whereas on the other one where a PFN has failed, the articular cartilage doesn't look bad, at least on this X-rays. On the acetabular side, And the femoral bone stock is also pretty well preserved when compared to a DHS. Options for management obviously are: number one, revision internal fixation. Second one is a prosthetic replacement. Indications for revision fixation are mostly in a young patient when you have got a very good bone stock and there is an acute failure of the fracture fixation or unacceptable fracture alignment, established non-union or breakage of the implants. So you can see this is one of our patients who had a breakage of the PFNA, and then we went on, removed it. He is a young chap, 35-year-old, limping all the time. We went ahead, removed everything and put in another PFN, and this thing's doing pretty well. The fracture's healed. Salvage options in older patients. There are lots of things which need to be considered technically in older patients. Whether to do a hemi or a total lip arthroplasty, that depends on the status of the articular cartilage. Whether to do a cemented or an uncemented implant, that depends on the kind of bone stock that you're dealing with. Whether a bone stock that you're dealing with can take a cemented uncemented implant is always a question mark, because these bones are always osteoporotic. Broken screws, bone loss, greater trochanter reconstruction, abductor mechanism is always destroyed in intertrochanteric fracture. So you need to have a plan to reconstruct the abductor mechanism, and proximal femoral bone deficiency because of the plates and screws. Hemi versus total lip, as we've already seen, if your acetabulum's gone, then you're heading towards a hemi, and if your acetabulum's intact, then if your acetabulum's gone, then you're heading towards a total lip. On the other hand, if your acetabulum's all right, then you could get away with a hemi replacement. And hemiarthroplasty can be monopolar or bipolar depending on a personal choice. Nothing to differentiate there. Broken screws, it is very common to find the situation where you have lots of broken screws and bone loss. You need to have all the equipment to take these screws out to put in a stem. And mind you, when you're doing a trochanteric fracture, then you might require a calcar replacing stem as well, because the proximal medial bone stock is deficient. Either you reconstruct it, use a long stem, or use a calcar replacing stem. Bone loss below the standard resection levels is quite severe sometimes, and you can get such femurs where you have a femur which is like a pipe really, and there is a thin bone around it. So here you need calcar replacing implants, or sometimes a cemented implant, because an uncemented implant would be dangerous and it can cause more problems. The bone quality, as I've said, is pretty poor in these patients sometimes, and because of the previous surgery, there is a lot of scar tissue as well. And as you're trying to dislocate a hip joint, you can fracture. You can fracture right from the tip of the trochanter to the supracondylar region. In worst case scenario, you can have a whole femur which is fractured, and believe me, it has happened. It has happened to so many people. So you should be ready to deal with even such circumstances where you have something in your armamentarium that you could offer the patient in case of such disasters. Cemented versus uncemented. Always remember the aim of performing surgery at this age to mobilize the patient early. So if you put an uncemented with an insecure fixation, it doesn't make any sense, because you can't make the patient lie on the bed for a long time. So I would rather have a cemented stem fixed firmly and mobilize the patient early rather than doing an uncemented fixation. And bone graft from the resected head is pretty useful in dealing with these patients. If you are using a cementless implant which is extensively coated like this, then you can break the femur, you can shatter it into a number of pieces, which becomes a disaster. And intraoperative fractures is not unusual. Always get an intraoperative radiograph if in doubt, or rather make it a habit of getting intraoperative radiographs when you're dealing with such situations, so that you can do something right then and there rather than waiting for later. Proximal femoral bone deformity. Due to fracture callus and fracture translation, malunion is often present, which increases the risk of femoral canal perforation during the preparation. The tracts which are formed by such malunited bones are normally very sclerotic, and you need a burr to remove them, and you need to be very careful because you can perforate the shaft. This is a study from Danbury. They've followed up 60 patients of whom they have done 32 hips and 27 bipolars, 32 total hips, and they have pretty good 7 and 10 year survivorship for intertrochanteric fractures, which they have salvaged with replacement. In our Indian setup, Pachore has reported it from Ahmedabad, and they have got 30 patients, of which 21 were hemis and 9 totalips, and they also gave very good results, but they do mention that it's a technically demanding job for which you need to be ready. Oh, these are a few cases of ours which I want to show. The first one is a 74-year-old male with a failed DHS and derotation screw which is eating into the acetabulum, and this was pretty straightforward. It was a totalip replacement was done successfully. Second case is a stovepipe femur with a ripped off DHS. You can see all the screws have come out. Here the priorities are, number one is to make sure that you got a stem which has got a good hold in the femur, and at the same time you have to reconstruct the trochanter and use the bone graft from the head to make sure that you've got bone on the lateral side which can heal. There's one more case, 60-year-old female with a failed DHS. Again here the same principles were applied to reconstruct the bone on the lateral side and reconstruct the trochanter. This is slightly unusual to see a non-union in a intertrochanteric fracture. This was a 27-year-old male with a 9-month history of fracture, and then he has visited everyone and all the massage centers in the state and ended up with us at the end. So we had the options here are, number one, to try and see if you can reduce it, but it's very difficult to get the length. It is very difficult to open this fracture, and you need to be ready to do a Diamond Houston kind of osteotomy to get the shaft in the beak of the proximal fragment into the shaft and do a DHS. Luckily here we could get the DHS done. We have a PFN failure. Mind you, when you have a PFN failure, your femoral side, you can see the defect is very small, so your primary stem can suffice. Summary: decision making is influenced by the location of the non-union, physiologic age of the patient, quality of the remaining proximal bone, deformity, hip joint cartilage, and viability of the femoral head. In younger patients, salvage of the failed hip, that is, preserve the hip joint, is the dictum, whereas in older patient, prosthetic replacement is far superior. Technically demanding procedures, so be careful, be prepared, and have everything available on your hand when you're planning such procedures. Thank you.
Thank you, Sunil Apsingi. Excellent lecture delivery about management of implant failure and non-union in intertrochanteric fractures.